It won't come as a great surprise to anyone on the webinar that we see patient centricity as the hot topic in the market at the moment, with maybe the exception of GDPR, which of course has been huge in Europe. And we see the demand for patient studies increasing month on month, year on year. So essentially what we want to do is have a look at how we approach patient market research, how it differs to HCP research. There are some really hard groups to reach within patient market research. Patients by their nature are hard to recruit, and I think currently we see the industry really approach patient work the same way it approaches HCPs, and as I say, it's a call to action to maybe offer an alternative solution. That alternative solution, to give it a kind of a brief summary up front, is this concept of pre-building panels and communities that can service the demand of the work that's coming forward. So if you look at HCP research, you might have some work with gastroenterologists, and they might complete a study on one disease area 1 month, and then in a couple of months' time they might be recruited to take part in another disease area. But with patients, it's very specific. So we could have a breast cancer study today and recruit some patients, but we might not have another breast cancer patient study that patient would qualify for a number of months or even years, and it's kind of hard to engage patients in that same ad hoc way. So what we have been doing is working with clients to pre-build panels when our clients can plan in advance the work that they think they're going to have as a drug comes to launch or post-launch. They know there's going to be multiple engagements with that patient community. We build that in advance, and what that means is it gives you a chance to accelerate your timelines for when you have the project go live. It gives you a chance to increase your sample sizes, drive cost efficiencies, and also we talk a lot in our industry about the patient journey. But when you have this kind of pre-built panel that you're accessing, it does give a great chance to generate these proper longitudinal insights as you can follow the patient along their journey. So, we talked a little bit about the work we're doing now, but I think it's important that we kind of have a look at how we perceive the current situation for patient market research. For kind of chronic but very prevalent disease areas, so kind of your asthmas, your COPDs, your diabetes, it's fairly straightforward to access these patients. There are some non-healthcare specific panels out there where these respondents exist and take part in a multitude of other studies as well. And it'd be quite cost effective to access these respondents for decent quantitative size market research studies. What we see is that once you move past these disease areas and you get into your more rare diseases or your niche disease states, that these respondents are far harder to access. And what the scenario we see quite a lot is clients coming to us saying, we want to do some work in like CTEF. The client wants to be out of field in 6 weeks. Do you have these patients on your panel? And that's very difficult. It's a rare disease. To be honest, most of the time you're always starting afresh with that kind of recruitment, and that's where it becomes challenging. And for our clients' point of view, and for N Pharma, that's when your timelines are likely to be longer. It tends to be a more expensive recruit. Sample sizes become very difficult for a quantitative survey, and as much as we try and avoid it here, you see best efforts over proposals because there's somewhat of an unknown element, I guess, to that kind of recruitment. So what we're suggesting today is that there's a need to change. The demand for patient market research, I can only see it increasing, and I feel that as an industry, and we're certainly addressing this here, we feel there's a need to maybe do things differently to drive success for these projects. A lot of our thinking has come from some work we've been executing with the National Health Service in the UK. So we're particularly proud and privileged to have the relationship we have with the NHS. It's actually been an award-winning relationship this year, and we've learned a lot in terms of the way we work with them. Because the NHS, from what I understand, have been very criticised for what was a tokenistic approach to market research, and they've had this huge drive for engagement with the members of the public and the patients that use their services on a daily basis. And what we've done with the Surrey Heartlands STP is we have gone out in advance and we have built them a panel of 1,800 respondents across various disease areas. So we've just finished doing some work in cardiovascular and hypertension as an example. And that panel is pre-built for them and they are accessing that on an ongoing basis, and we work with them to help them engage it. It means that when someone in their research team wants to run a custom piece of quantitative research, it's extremely quick for them to access that panel. It's questionnaire design, interfield, gather your data. It's not weeks upon weeks of trying to find the right respondents. They know they already have them. Likewise, we do some co-design days with them, which are really fantastic to be involved with, very interesting. But again, because that panel is pre-built, it's a really straightforward recruit, and they're utilising that panel for in-home depth interviews, tele-depths, and then we're looking at more advanced research techniques with them as well, because that asset is already built for them. What it means for them, it's an upfront investment. So I guess in the scenario of the NHS, they know what research they've got coming. It's very easy for them to plan. They know who they want to target. So there's that upfront investment, but every research activity we have with them down the line becomes, I guess, more and more cost efficient and much quicker. Likewise, they get the chance to drive longitudinal insights by working with a variety of patients on different engagements. So I think what's really important to note with the learnings we've had from the NHS is that by working in this way, where one can plan in advance, and I'll say up front, we appreciate this is not always the easiest thing to do, to plan knowing what work you have coming down the line, or for your clients, if it's pharmaceutical companies, to know what they've got coming down the line. And there will always be a need for ad hoc patient market research. But we have found that where we can have that pre-planning and we approach it in a much different way, that all of the challenges that we've seen previously with patient recruitment, that they do disappear. We overcome them quite easily. It becomes more cost effective. The recruit time is far, far quicker. So it's certainly something that we are very keen on here. We've been running these in the private sector as well, and Laura will come on to that subsequently in her half of the presentation. The one thing that I think is really important, and it comes across as really as a fringe benefit, but I think it's so much more than that, is that once you have that community and it's built and you're working with it on various research engagements, it is possible to follow a patient over a period of time. So at the moment, when people conduct ad hoc market research with some patients, we've just completed some multiple myeloma patients in home. Obviously, they're great pieces of research that our clients are conducting, but you see that patient really on one day, and you might talk to them about the past or the future, but depending on how they feel that day, or maybe they've just had a bad day, aside from their disease, you get a picture in time, and I guess that might not always be representative of how they really feel. But we find that when you can work with those same patients over and over time, first you can engage with them outside of market research, and Laura will come on to that as well. But secondly, you do really get a much more well-rounded view of that person. You can drive, in our opinion, kind of far, far superior insights. So that's really my part of the presentation, really kind of setting the framework of where we feel we are as an industry with patient research, the challenges that we see across the board in terms of the recruitment and engagement of patients for market research. And as I say, there will always be a place for custom ad hoc patient recruitment. It's something that we are fully prepared for. We just feel that it'd be interesting to kind of put this forward, and if it sparks a debate and we get some feedback and questions on it, then even better. We have seen success with this. It might not work in every scenario, but we see this kind of pre-planning, the pre-build of a patient panel for a disease area as a way that does overcome a lot of these challenges. Anyway, so I will hand over to Laura. I've had the easy bit talking about the theory. Laura's now going to take you through the practice.
Thank you, Tom. So, as Tom mentioned, We've built panels within hypertension in the UK, but we've also built patient panels in the US with breast cancer and psoriasis patients. So this slide here is an example of the type of timeline that a patient community or panel build can have. The example assumes a panel of MS patients with a commitment of 1 year. It's purely an example, and the panels can run for more or less time than this depending on what's required. So we start with the actual community build, and the time required for this is really dependent on the target and the sample size that's needed. Once the panel build is complete, the community is launched with a welcome email and video. This communication would reiterate what was explained to them when they were recruited, so that all participants are onboarded and understand what's expected of them. Throughout the course of the community, we engage with the respondents on a regular basis through a variety of mediums. As you can see from this slide, the participants would complete surveys, take part in bulletin boards, as well as in-person research across the period of the community. Some participants would take part in all tasks, others may be selected based on how they responded to a poll, their geographic location, or other quotas. The requirements are completely flexible and can be defined as desired by the objectives of the community. If we have a period where there is not an official task for the panellists, then we will create one so that the engagement level doesn't dip. For instance, we can share some content from a physician's pulse survey that we've run on the therapy area. So in order to build and maintain a successful and insightful patient community, you need to begin with the recruitment process. Firstly, identifying how to source the right target for these communities through the most appropriate recruitment methods. These methods can include recruiting through social media, advertising, and also, and most often from our experience, through referrals from healthcare professionals, support groups, and charities. When we're recruiting via referrals, our teams will connect with support groups and patient associations, as well as healthcare professionals. And when we are engaging with these groups, it is really important to set clear expectations from the start. When we ask groups to refer their members and medical professionals to refer their patients, we need to be entirely transparent as to what is expected from the participant. For instance, what time commitment will there be per month, what type of tasks they will be completing, and what their participation will contribute towards in terms of outcomes. For the respondent themselves, they will want to know, what's in it for me? We have to set our stall out from the start. What do I get out of this? What are the benefits of me taking part? They need to understand what they'll gain from taking part in this community, both financial and otherwise. Once the community has been built and we have all participants on board, it's important to provide consistent and regular communication, which is in line with the expectations for engagement that respondents had when they were onboarded. It's imperative to provide accessible tasks. Polls and surveys are quick and easy to complete, and results can be shared back in a timely fashion. Balancing the type of exercise between those which have a short time commitment and those with a longer time commitment will keep the experience varied for the respondent. It is possible to panel where panelists can engage with their peers and build connections, almost becoming a mini support network within the community, if this is considered appropriate by the community sponsor. Where possible, it's great to be able to share some of the insights generated from the community in some form, even if it is only the survey or poll results. So when we're looking at why we should build patient communities, as we've seen, there are a number of reasons. Looking at our relationship with the respondent, the nature of the long-term engagement changes that relationship from being transactional to being a partnership and fostering loyalty. This provides greater insight and results in there being less attrition. It also allows us to recruit through greater collaboration with the support groups. By engaging in this meaningful way, we increase cooperation. And it gives greater access to patients for the research. This approach provides flexibility on how and when to engage with respondents, rather than having to do so on an ad hoc basis, with limited recruiting time, and always having to start from scratch each time. If an additional research question is raised, an extra survey, for instance, or an additional round of telephone interviews can be included in the community to address this question with minimal setup and launch time, as the community is already set up and in place.
Thanks, Laura. Perfect. I mean, from our point of view, just to round things off, before we kind of hand back over to Hannah and hopefully get some, I see we've had some questions come in, which is great. I think it's just really important to really clarify the position on this. Patient research, it's only going to keep growing and keep increasing. Patients are at the centre of research more and more. The requests are only going to get more difficult from end clients because they're going to want to look to reach hard to reach patients. I think collectively we all need to work together on this to find solutions, and this is just one proposed way forward. We've had some success with it in the public sector in the UK with the NHS, but we've also had success with it in the private sector and have built these panels in both breast cancer and plaque psoriasis in big numbers. There will always be a place, of course, for the the quick term ad hoc. We need this out of field in 4 weeks, custom recruitment, because research needs do arise last minute and need to be satisfied. But where we can pre-plan together and we can find ways of accessing these hard to reach group numbers in big numbers, and I think it can only be beneficial for all of us. So that's it for our part of the presentation, and we'll hand back over to Hannah and hopefully have some questions.
We do. So thanks, Tom and Laura. That was really insightful. While Tom and Laura go through the questions, I'll take the opportunity to cover some housekeeping. It's become a bit of a tradition from these webinars to advertise the next one. So our last webinar in the series, it was always going to be 4. Unfortunately, we can't stretch summer past September. So the next webinar is on the 13th of September, and it looks at the opportunities for gamification in healthcare market research and how we can move the story on from thinking about things like space invaders that don't really have any place in healthcare market research at all. So at the end of last year, we did some proprietary research with physician respondents on different applications of gamified techniques, and one of the parts of the webinar is sharing those findings with you, as well as our recommendations for applying them to healthcare market research. And one last thing before we go back for questions, at the end of the webinar you'll be taken to a survey. Please take the time to complete it. It shouldn't take you more than a minute or so. We know how great market research professionals are at actually completing surveys. But particularly the section that asks for suggestions on future webinars. We've really enjoyed doing the webinars this summer. We'd very much like to do them again, but we really want to make sure that we're covering things that are important and interesting to you. So your feedback, particularly on that bit, although I'm sure Laura and Tom would love fantastic scores on their bits as well, would be great. But from my point of view, feedback on that part would be brilliant. So over to the questions. So we've got a few that come in. Right, first one. What happens to the panel if we don't use it for 3 to 6 months? Do we need to start from scratch?
So I think the key with that really is that's when your fieldwork supplier, in our case, how we would do it is we would step in then and run some engagements on your behalf. So we would run some pulse surveys and share the data back with you. We'd keep it, fairly general, and we'd find some means to ensure that those panelists don't sit there with the whole concept of what they joined kind of dwindling away, so we have to start from scratch. I think the key with that is that will happen from time to time, of course. You don't want to force research for the sake of it. That's where having a really good communication between all people in the chain, all bits in the chain, is the way to do it. We can pre-plan in advance how we keep that engagement high.
Great, thank you. Next question, are the panels private? If the NHS has generated the panel, can other companies use it? Tom?
Yeah, so it depends really. We've had different arrangements on this. With one of the clients we work with, they were so confident that they would use it 2-3 times a month, and they didn't want anyone else to access it, so that's really their private panel. But in one of the other cases, the company definitely had a need for that panel, but were worried about having some blank periods where they weren't going to engage with it, and actually the thought of their panelists completing other research surveys was quite a positive for them. So we've done a few of these. It's not like an off-the-shelf solution. It's very much, you know, open for conversation. Really, it can work either way.
Right, another one. Are there any disease areas where you wouldn't advise using a patient panel? Laura, maybe one for you.
I think with this, it's what we've seen, and when we've discussed some options on this before, is you get some more rare conditions where if the incidence is pretty low, you may not be able to get a large number of patients on the panel. But what you can look at doing there is some kind of pan-European panel. And this was something we discussed with a colleague back at Ephemera on a similar topic. So I think there's, I'd say if there's an interest in doing something like this, speak to us about it and we'd be able to sort of advise if we feel it's the right fit.
Fantastic. And kind of lumping two questions together. So the first question was, does the time commitment have to be 1 year? I think that's relating to your timeline that you showed, but also how long in advance do you need to be pre-building the panel?
The timeline doesn't have to be a year. It made a much easier slide to show a year, but it can be shorter engagement. It could be 3 months, 6 months. Some engagements last for longer than a year. So it really depends on, the objectives and exactly what you're looking to get from the panel. Looking at how long the actual panel build takes, that varies depending on the exact therapy area, the samples, and the sample size and the markets that the panel is looking to be built in.
Great, and I think the answer to this question might be similar in terms of it depends, but is this realistic for a small sample and or a client with a small budget?
Yeah, I mean, it absolutely is. This can work in a multitude of different ways, and since we've had some conversations around this, we've had lots of different scenarios, but in terms of the small sample size, we've had one conversation where someone is looking at a particularly niche area in quite a small market, but have discussed maybe collaborating with another business in that area to do that together, if that makes sense, to share that cost out. And there's absolutely no reason why that can't happen. So I think, if it's a really niche disease area, a really rare disease, realistically, whatever we do, it's always going to be hard to get a quantitative sample. So if you're looking at then at building a qual panel that you're going to go to over and over again, then that's a good way of doing it. Just answering that question, it's just jogged my memory on something that kind of ties in a little bit to that in terms of kind of small recruits. One of the things that's also quite interesting with this is that when we conduct HCP research, even though by its very definition what we all do for a job is very niche, like doctors are very niche of the population of people, it's still possible to get big sample sizes per market of most physician types. What we're seeing with patients when it is quite niche is actually for a quant sample having like a European sample. So instead of having like I want 50 patients in the UK, 50 in Spain, having that look at like 50 quantitative across those markets. So that's another idea we can do for those kind of hard to reach groups.
Great. I think that's all the questions that we've had in, and certainly pretty much all we've got time for. If you do have any other questions, as ever with the other webinars, you can send them to me. My email address is the one that's on the Zoom webinar email. It's hannah.brown@eu.m3.com. And then Tom and Laura can get back to you via me. As with the other webinars, again, we'll send out a full audio and video version of the presentation, although a slight disclaimer, I forgot to press record at the very beginning. But I think I got as Tom started, so it'll just be my dulcet tones that you're missing. And you'll get a copy of the slides as well. As with this one, we put all of them in the resource section on the M3 Global Research website. So when you go onto the website, you click on Enter as a Client and then Resources in the horizontal nav, The webinars are there, along with all sorts of other resources that we put together recently. There's quite a lot on GDPR that you might find useful. So all of those are there on demand, and as ever, if we can help with anything, do ask. Thank you for joining us again tonight. We hope to see you on the 13th of September for the next one. Thank you.